I don't see many patients in my facility, but I do have an opportunity to crush a lot of drugs. I like to cause clogs. That's what I live for, to cause lots of clogs. So, and so they asked me to come down here to talk about the ENFIt issues. I didn't have an opportunity to actually work with the ENFIt devices in many of my studies, but I did look at many of the issues that are associated with it. Also, I have a disclosure to make. BD hired me as a consultant, more like an insultant actually for them, and so I got to see some of the designs and situations there, which I can't always talk about, but I am going to talk about some of the issues that I think are really important that haven't been mentioned so far. So, oh, I can see it down here. Okay, so as you guys already know, it's different. It requires special adapters, etc. The other way sometimes is considered faster, and who knows whether or not the port is actually an issue. You know what I thought was interesting is that this whole Stay Connected, I got one of those little tube attachments they're handing out at the JEDSA thing. Mine at back in my lab says Stay Connected 2014. Maybe we'll get around to it soon. Anyway, that's what I thought was interesting on the bottom there. The thing that gets me about the ENFIt is pharmacy. Pharmacy hasn't actually been involved so much with the drug preparation. It's not always been an active participant in preparing drugs for feeding tube use. But now in the hospitalized setting, they now have to take an active role. In the past, if a patient was on a feeding tube, it could easily just be put into an oral syringe. Now it has to be put into a special ENFIt, and the pharmacist has to be aware whether or not the patient has a feeding tube or just needs a liquid. And that's going to be a change in dynamics as pharmacists now have to be familiar with the issues of administration. If one of the devices with the ENFIt is that it has a straw attachment, that if you mix a drug, you put the drug in a cup, you crush it up, you pull up the volume from that cup, those straws are quite fine. They do not accommodate chopped up drugs. And as our speakers have already pointed out, is that solids will cause problems. So most of the times in the past, we said crush and flush. It went through a Toomey syringe. There was no problem. Now with the ENFIt, there will be a bit of a gap. Also, one of the things I noticed, we did audits of hospitalized patients. Most of the order entry systems in the hospitals do not specify the feeding tube route. We did an audit of our own institution. We found 90% of the orders where medications were being administered through a feeding tube, the feeding tube route was not indicated on the order. And so now we have to adjust for that type of situation. Before we had a attachment was male to female, now female to male. There's actually a certain amount of dead space that's on the end of the syringe. So if you look here, there's a, is there a pointer on this thing? Oh, yeah, whatever. Whatever. So if you look at the feeding tube design, there's actually a dead space on the very end, and when you try to draw it up with a straw, you get air into the syringe. Pharmacists hate having air in the syringe because that means they're handing out an inaccurate dose. It takes actually longer time in order to prepare the dose. So there we go. And also there's a bit of residue that sits, oh, hi.
One has a laser pointer.
Oh, that's the pointer. Oh, hey. Oh, yeah. All right, so somebody has the point. All right, so there's a little bit of residue that sits on the end here, and that has a tendency to drip. Also, as you pull up with a straw, you get air holding into the situation. ISMP came out with some stuff on this. ISMP, wonderful organization, Institution of Safe Medical Practices, looked at the issue that this dead space that's sitting on, oop, hello, I hit the wrong button. That's all right. Let me go back. There we go. The dead space on the end here actually contributes to the volume of the syringe. And with that, if you draw up a very small dose, you can actually wind up giving a much larger. So if you're giving a concentrated medication, you have to be very careful with the ENFIt design. They have made an adapter for this device that allows you to avoid this type of error, but it's something to be concerned about. You guys already heard this stuff. I'm not going to belabor that. This is, I thought, was interesting. There's a company out there making a brush to go into the other end of the feeding tube. Apparently, it's accumulating a lot of the enteral products. I don't like that. I don't like dirty tubes. But this is something that we are going to have to be thinking about. They have to be brushed because they do accumulate. Because as the drip comes down, there's sort of a collar at the end. Here, let me see if I got that back here. So here, come on, go back. There's a collar on the end, and so this area here accumulates residue. So we're going to have to be concerned with that. This is a YouTube video. My student helped me out with this. There is a, here we go. They used the proper way of drawing up a syringe, and while they were drawing up the syringe and making the connection to the tubing, drips were occurring. It was not part of the actual demonstration to show that there were drips, but we found that when we tried to do manipulations in my lab, we found that there were drips occurring. It's because the reservoir on the end of the syringe actually holds fluids, and when they make the connection to the fitting, it actually causes drips to occur. Where that becomes a significant issue, I work for Memorial Sloan Kettering Cancer Center. Everybody knows what kind of drugs we play with at Sloan Kettering. So we're concerned about that dripping out. Some of the medication issues, those who haven't heard any of my talks before, there's issues associated with the thickness of the drugs, shiny tablets. If you ever have to crush up a shiny tablet, remember that a lot of times they're shiny because in order to enable you to be able to swallow them easily. The shiny they are, the more they also will react with water and they will form a gel. And we've seen a number of problems associated with that. If you have drugs that have that type of shininess to them, if you use an acidic liquid like maybe apple juice or something like that, you actually will cause less clumping. So that's always an alternative. Also, mixing with water enhances delivery, but if you only use water with some of the shinier products or coated products, they will also cause clogging. Keep in mind, a lot of times one of the reasons the drugs have a shiny coating is that they are what they call enteric coated, so that they're trying to avoid deactivation with the stomach acid. You should check with the pharmacist to see whether or not crushing is going to be a significant issue. Rinse. Snakes in the grass. Most of the excipients are considered grass. That is generally recognized as safe, but they also contribute to the formation of clogs. Thickening agents, they allowed you to keep the suspensions uniform, allow the drugs not to settle out so that when you draw up a liquid, that whatever dose you're trying to aim for will be uniform throughout. The problem is that they also have a huge amount of cellulose. Cellulose does not dissolve. And believe me, I have tried to work with that as an agent. When you have a product that has a lot of cellulose, you're going to require a lot more rinsing. So if you look at any medication and you look at the tablet and the tablet says maybe 5 or 10 milligrams, but your tablet is large. Take, for example, I don't know if anybody's been on Lipitor. Lipitor is a 40 milligram tablet, but it's the size of, some choke a horse. The reason for that is because the drug has very poor solubility. So in order to enhance that delivery, what they do is they grind it up to a very, very fine powder, mix in a lot of cellulose so that when you take it, it basically explodes. And in exploding allows for the drug to be distributed in very, very small particles. That also means that there's going to be a lot of cellulose in there. So when you give this drug through a feeding tube, you got to use a lot of rinsing. We did a cyclovir. We took a cyclovir tablets. I don't know if you've ever seen those lovely items. I mean, you really want to choke somebody with something. And we put it into a test tube with about 5-10 cc's of water. The cellulose started to expand. It came out of the tube, rose up. We thought it was going to take over Brooklyn. But it's a lot of fluid. When you see tablets of that size, consider that you're going to need a lot of fluid in order to get them through the tube. A lot of drugs have, a lot of the newer drugs that are being developed are active on the cell surface. So therefore, on the cell surface is more lipid-based. They have poor solubility, so a lot of times they have excipients and other ingredients added in order to make them more water soluble. They also will require more fluid. They're designed to dissolve in the stomach, and they get absorbed once they reach the jejunum. So, gee, you're swell. That's what it is. They got to swell up. So when the drugs go into the stomach, they react with this acid and then get dissolved. So we're putting together a list. I've got tables of about 300 medications. We haven't worked them all out, but one of the things we find is that a number of drugs, when we crush them up and add them to water, they have high osmolarity. The osmolarity is the amount of stuff that is dissolved in a particular liquid. If you have a very high osmolarity and you put that into an environment that has a low, like your stomach or even lower into the jejunum where there's very low residual capacity, you actually will feel a cramping into that environment. My advice, dilute it a little bit more. The Mesna, not often used here. Metformin, any patient's been on metformin, if you crush that up, you'll find there's a lot more GI. If you add more water, you can avoid that type of interaction. Also, I also advise patients who getting meds through the feeding tube, look at a website. My favorite website is rxlist.com. It tells you whether or not the drug has low water solubility, and that will give you a clue whether or not you're going to need a lot of extra fluid in order to administer the product. If you see an ingredient called povidone, povidone is a coprecipitate, and many times drugs that have that have a lot of solubility issues. There's something called class 4 drugs. I don't think you'll find that much in your literature. I have difficulties finding it in my literature. And drugs who are class 4 have very poor water solubilities and poor transport. And so it's an area to consider. So what else we got here? What's this? Rinsing the tube, as I mentioned, the beads are enteric-coated. A lot of times the resistant, allow for resistance to acid. Mix it with a juice. That's the best way to do it. If your feeding tube is past the pylorus, don't use the juice. You need to get that enteric coating off first in order to have the drug delivered in that environment. The pH is the important. The best way to do it is mix it with sodium bicarbonate, baking soda. Allow the product, the enteric coating, to come off and then flush. Drugs that have this type of problem, pancreatic enzymes, tamsulosin is also another agent, and all the PPIs have enteric coating. A lot of beads are in products. If you open up the capsules, you'll find there's a lot of little tiny beads. Where this became a problem, I noticed 2 drugs, Emen and Sporanox. It turns out those particular drugs, the beads are not enteric coating. What they are is the drug is actually sprayed onto the surface of a sugar granule. And as the sugar granule dissolves, it takes the drug with it to allow it to dissolve. My recommendation in drugs that have this type of problem, don't try to mix it in a cup. What you do, open up the back of the syringe, open up the contents, put it in the syringe, pull up fluid, and allow it to dissolve in the syringe. Keep it all together. Don't separate it. There are pharmacies out there that will mix up an Emend or other products in a bottle. Most studies that we found, the drug pretty much falls all the way to the bottom of the barrel, and it falls out of solution. Best thing to do in low soluble drugs, keep it in the same syringe. You'll find it a lot easier and more reliable. So I tell people if it's scored, it can be crushed. Somebody brought up to me in one of the talks, not for toprol. So you got to read the actual literature on this sort of thing. Toprol is actually a wax matrix, doesn't crush up very well. That's another thing you have to be careful with. Shards. Somebody tried to crush up Lipitor. It doesn't crush. Some of these drugs are very hard type of tablet. It's easier to let them dissolve in a syringe than it is to try and crush it with a mortar and pestle. You probably will find it almost impossible. Not a mortar and pestle, more like a sledgehammer in some of these drugs. Try to crush a ciprofloxacin tablet. There's one for you. Actually, we have many of the nurses use a packet that they use, they put into a machine called a quiet crusher, and they pound on it in order to break up the tablets. Ciprofloxacin was so hard that it poked right through the bag. So something to consider about. One of the things we're always concerned, and I have to mention in every talk, is extended release. Be very careful. Make sure your product is not extended release when you crush it up. Drugs that are extended release can release the entire contents very quickly and wind up with toxicities. This one drug, Trentalo, also known as patoxyphylline, it can cause significant effects if you crush it up. But you could put it into a liquid formulation and administer it more frequently, and it's safe to give in that fashion. Hazardous drugs, that's what I live for. Don't crush oral chemotherapy, but you still could put the drugs into a syringe and allow it to dissolve. There's a new chapter of the USP called Chapter 800 that is addressing a lot of the issues for healthcare workers because of their exposure to chemotherapy. One of my concerns is that extra drip that's on the end of the ENFIt syringes. Is that going to expose workers to when I prepare a product, a chemotherapy agent, in an ENFIt syringe? Will that drip before it's administered? And that we need to resolve. Some injectables can actually be given through the feeding tube as an alternative to capsules. We found that etoposide and Cytoxan was okay in that setting because if you have a drug that's in a capsule form, you don't want to open that capsule if it's a chemotherapy agent. On the same hand, capsules don't dissolve very well in the syringe, so that's another area. There's been recently I got a call, they wanted to give finasteride, Proscar. It's a common drug for men with prostate issues. It turns out because it's a hormone, if you crush it and you expose the worker to the powders, it is a male hormone, and if that person's pregnant, it could affect the worker. So this has become an area of concern. So what we've been trying to do in that setting, again, take the drug, put it in a syringe, draw it up, keep it contained. That's going to be an issue. I just got a call yesterday about this other drug, panobinostat. It's a new chemotherapy agent. It actually has Ames test is a test of whether or not it has a risk of carcinogenicity is exposed. Again, another type of thing. It's a drug that needs to be kept in a syringe. Syrups are thick. Try to avoid them. Dilute them. I always try to think. Pharmacy compounding is the big issue. Pharmacists like to use or sweet in their mixings, and I always tell them if the patient has a feeding tube, they don't really care about the taste. So there's an alternative agents, Oral Plus and Searspan. That's another alternative. I also run across a number of compounding pharmacies like to use simple syrup as a mixing agent. Try to get them out of that habit. And osmolarity, we kind of already talked about. Oh, there was one thing there. We actually gave generic Lomotil one time, and it caused diarrhea. The drug was actually used in order to treat diarrhea. It had sorbitol as the excipient in the product. Used a lot of water to avoid the clogs, and thick as a brick. This is one of the drugs we broke up here. As you can see, cellulose can really accumulate into some of these syringes. Here's some of our other clogged syringes. The amount of excipients can really get thick, so you need a lot of stuff. And here, capsules don't dissolve. And The best way to dissolve a clog, a lot of water. That's our studies we've already published on that. A lot of nurses tell me they use colas, and colas work if it's a drug. Okay, I'll shut up soon. There's a new device out called Tube Clear. It's very expensive, but it's really a cool device. Breaks up the clogs very quickly. So, and my recommendations: rinse for tubes greater than 18 French. The internal port is a little smaller. Anyway, rinse and rinse often, and that'll close. Okay.